Good afternoon, everyone. There is a subject which has very great importance because of the great mortality and sequelae of the survival will develop in 4% of them what's called chronic thromboembolic pulmonary disease. Every effort must be made in order to decrease this number, huge number of mortality and huge number of sequelae of the pulmonary embolism. I have two guidelines. One was published in 2011, which divides the cases according to their risk stratification into massive and submassive pulmonary embolism. Obviously, there is nothing to fit all, and it is very difficult to manage all the cases by a dichotomous provision that they are either massive or submassive pulmonary embolism. Comes next is the 2019 guidelines, which also left us in some perplexing way. Which classification should I apply? And most important, who is going to be treated at home? Who is going to be admitted into hospital? In which part of the hospital should the patients be admitted? Into intermediate, into wards, into intermediate ICU, into ICU, and to whom should I give the patient advanced treatment? Means thrombolytic therapy, catheter-directed thrombolysis, or mechanical thrombectomy, or even to give the patient pulmonary embolectomy. Until comes the latest one, which is 2026, to answer many of these questions. I'm building up what's important from this. All of the presentations of the pulmonary embolism cases are lacking certainty about the diagnosis because of the symptoms and signs are non-specific to the pulmonary embolism. Therefore, we have to apply one of the probability scores. Unfortunately, each one has its applications on the mobile phone, and you can calculate the risk of the patient in a matter of a few seconds. This is the Wills score and also the pulmonary embolism rule-out criteria, which is the PERC, revised Geneva score, and so many as you know. What we should do for the patient next step. If the patient is low probability and could be excluded by the pulmonary embolism rule-out criteria, nothing should be done. And if the patient is in the intermediate zone between 15 or 50% probability of having pulmonary embolism, you have to go for the D-dimer and the years score. D-dimers all of us know, and the years score, which refers to clinical sign of the DVT, hemoptysis, or the pulmonary embolism has no alternative diagnosis. Each of them has one. And if your patient is 0 years and below 1,000 of the D-dimer, you should not do for the patient further investigations, and you have to seek the diagnosis elsewhere. On the other hand, if the years is 0 and the D-dimer is above 1,000, you have to go for imaging, as we will see later on. If the years is 1 and the D-dimer in this case is below 500, this can exclude the presence of the pulmonary embolism. If the years is 1 or more and the D-dimer is above 500, you should go for image to your patient. Which type of image? CTPA has become the gold standard because of the availability, because of it is quick, but the most important because it can delineate the peripheral lesions, and it also give an idea about the right ventricular and left ventricular ratio, and also it can provide alternative diagnosis in case pulmonary embolism has been ruled out. Planar ventilation perfusion scan is much inferior than the CTPA, but which is equally sensitive to the CTPA in terms of the pulmonary embolism is the VQ single photon emission CT. But it lacks any idea about the right ventricular enlargement and also cannot provide use alternative diagnosis. If you have a case who is pregnant woman, this is a special case of having pulmonary embolism, you can go for low-dose CT-PA according to the current guidelines, or perfusion-only scan. Both are permitted in the in the patient who are pregnant. What about the duplex ultrasound? Duplex ultrasound is its absence of the DVT on duplex ultrasound scan does not exclude pulmonary embolism, because 41 to 74% of the cases have no DVT diagnosed by the duplex ultrasound. But it has advantage because it has a prognostic value. It has been found that patients with DVT, with positive D-dimer and CTPA is positive, have higher mortality than patients who do not have DVT with pulmonary embolism. Also to identify the iliofemoral DVT that could be treated accordingly, and also help decision making about the filter insertion in such cases. We come to the risk stratification according to the 2026 guidelines, the most recent. They go through from A, B, C, D, and E. We have some remarks over here. This is a pointer. Yes. This is the difference between B and C is the severity score. And here is some expression which is somewhat new: incipient cardiopulmonary failure. This is we have to consider. And this is one normal biomarker, and this one is a role of the echocardiogram. I'll show what they meant by this. Severity score, you have to apply one of these severity score, pulmonary embolism severity score, or the simplified pulmonary embolism severity score. So many scores are present. Unfortunately, this is severity score calculate the risk of the patient right now. They are not longitudinal. They cannot judge what will go next on. It help you to put the patient into one of these classifications we have just mentioned. The echocardiography can be performed on two protocols, either goal-directed or it is for formal transthoracic echo. It is not intended to diagnose PE. This means if there is no finding inside of this, you should not rule out pulmonary embolism till your patient has pulmonary embolism. This is the right-hand photo, shows the changes that could be taken into consideration while performing this transthoracic echo. The biomarker and normotensive shock. What's meant by normotensive shock? Normotensive shock is the patient who is maintaining blood pressure, but there is hypoperfusion in the periphery, or in the viscera, or in the kidneys. This is could be picked up by finding of the serum lactates more than 2 millimole, urine output less than 720 per day, or increasing the creatinine by order of 0.3, or the cardiac index less than 2.2 liter per square meter surface area of the patient. Biomarkers that we go for, either troponin or a brain natriuretic peptide. Usually we do both together in order to put the patient in one of these classifications, because it will dictate much of the things we have questions about. Who is going to be admitted? Who is going to be treated at home? In which segment of the hospital should these patients be put in, or also the use of the advanced therapy. The PERT team, as you see the components of this PERT team, and thanks for Dr. Ahmed Hussein who talked about this. PERT team is activated from the C onward, C, D, and E, but there is no need for this PERT team in the A or in the B. We come for the management of this patient. This category could be treated at home. This category could be offered could be offered 2 minutes, please. انت هكمل
2 minutes, please.
المزيكا عالية قوي. 2 minutes more, Dr. Ryan.
Yes, please. 2 minutes.
This patient could be treated at home. This patient could have a short hospital stay and can be kept into ward, not into the ICU. And also the C could be in intermediate ICU. From D onward to the E, this patient should be in the ICU. All the patients should be given anticoagulants. Some of this patient could be given the advanced therapy, which is the thrombolytic therapy, which is the catheter-directed thrombolysis, or mechanical thrombectomy, and also the ECMO. This should be start from D2 to from D through E. In summary, we have to suspect, confirm, or rule out this pulmonary embolism by probability score and imaging. You should assess the severity by severity scores, by biomarker, and by the echo. You should categorize the patient and activate the BERT team when it is indicated, and implement your treatment according to your availability and experts. Thank you for listening.